So you may be familiar with the standard way in which new drugs have been developed, and this really has been true for as long as I went into oncology in about 1978, and it really hasn't changed. So the first phase, if you ask people, an oncology fellow, what's the purpose of a phase 1 study, they'll say, well, the purpose is to find the maximal tolerated dose of the drug under the perhaps incorrect assumption that there's a relationship between toxicity and response. And then once you determine that MTD, then the second phase is phase 2, and it's basically a single-arm study in which you try to assess efficacy. And then finally, if you think that there's sufficient efficacy, you proceed to phase 3, in which there's a randomization between the new therapy and the conventional therapy to see if, in fact, the efficacy actually bears out when you compare it with a standard. But one thing I think is really apparent is that this approach is perhaps too nice a term, because I think it really does ignore clinical reality. And in particular, it focuses on only one outcome. And all these other things here, it ignores heterogeneity, that the patients are very different. It's insufficiently adaptive. And by adaptive, I mean it changes as it goes along, depending on what happens in the previous patients treated in the trial. It delays comparison, despite the fact that the question that patients are interested in is not whether a drug is good, but whether it's better than other alternatives. Because at least in the field of AML, I think patients frequently feel that, gee, there's really no therapies, I have a horrible disease, there are really no therapies. But the fact is that there are many therapies. If you were to go to the NCI website and look under AML, you'd find many, many therapies that are listed. And the real problem, because we know so little about the science behind the disease, everything has to be done empirically. You try it and see if it works. And the question that the patient would ask is, okay, well, you have a drug here, drug A, but is it better than drug B? But that process, for many reasons, some of which has to do with pharmaceutical companies, is delayed. And then when people do randomized studies, there is sort of like a set way of doing them. And there's a false positive rate of 5% and a false negative rate of 20%. And that's the same for all diseases. And let me get into this a little bit later, but I don't really think that it's appropriate to have it the same for all diseases. So for example, in AML, the consequence of a false positive, where you would replace an old therapy with a new therapy, is not as great because the old therapy was not very good to begin with. The consequences are not as great as if you replaced a new therapy with an old therapy that was effective in, for example, hypertension. So we'll start focusing on this. The trials really only focus on one outcome when they should focus on many outcomes. So as I mentioned, if you were to ask the usual oncology fellow, what's the purpose of a phase 1 study? They say, oh, it's to find the MTD. But I think if you were to ask a patient, why do they enter a phase 1 study, their goal is not to achieve no toxicity, but their goal is to achieve benefit. And furthermore, once you're done with a phase 1, you may be very uncertain about the real level of toxicity because the numbers of people treated in the phase 1 are relatively small, and they differ. We'll get to that in a second. And from that, it follows that we should adaptively monitor both response and toxicity in these trials. And in fact, really, they should be conjoined. And, oh boy, okay, so and one convenient way of doing this is through application of Bayes' theorem. And I guess it's sort of like saying the way you start is you set with a prior probability of a hypothesis. So for example, and then you observe data. And then you integrate your prior probability with the data to come up with a new posterior probability of the hypothesis. And I don't know if this can be seen too well, but or I can get the mouse to work. But the surface is a little flat. Okay, but we'll just try to explain it. So the curve all the way to the left. So, okay, so first of all, on the x-axis is various rates of complete response with a new drug in AML. And on the y-axis, of the likelihood that you're going to see that response. And this is designed for patients who've had AML, they've been treated, they got a remission, and they relapsed. And historically, the response rate in these patients is around 15%. So that curve all the way to the left if you see the weight, the height on the y-axis is greater somewhere around 15%. And what that says is what I think is most likely, this is before I start the treatment, this is the prior probability, is that, gee, most likely the response rate will be around 15% because this is what's happened many times before. And there's some possibility that it'll be 20%, there's less probability that it'll be 40%, and virtually very little probability that it'll be 60% or more. The second one, moving from left to right, now let's say you treat a number of patients. And in fact, the response rate in those patients is considerably higher than 20%. So what happens is, as you might imagine, your prior probability is altered because now you've observed the data, and now your posterior probability shifts toward the right. The mean now might become 40%. And then as you go on and continue to treat patients, and if that response rate holds up, the thing moves further to right, and its dispersion, its width becomes more narrow because you've got more information. And this becomes relatively simple to say from this kind of exercise, what's the probability that the response rate is greater than 30%? And to me, this is a lot more useful than a p-value because a p-value really doesn't, the question that you're really interested in knowing is, okay, what's the probability that the response is greater than 30%? What's the probability it's greater than 40%? And the p-value doesn't really give you that information. It's not a particularly informative tool, but people love to use it. So there's this concept of Bayesian learning in which, as I mentioned, the posterior becomes the prior. So you start with a prior, you observe data, then you get a new posterior, and that posterior becomes the prior. You continue to observe data. The process is repeated. And the posteriors become more informative as the data accumulate, and they shift to reflect the average behavior of the data. So what we have done is come up with a phase 1/2 design, and many people have published on this, and you can do this using p-value-based methodology as well as this. It's just that we're used to this. And we're doing actually a study with this with a drug with a combination that's called bendamustine and idarubicin in older people with untreated AML. And so you say, okay, we're going to define our priors for response at each of the 4 doses. And similarly, we'll define our priors for toxicity at each of the 4 doses. And the patient can have any combination of response or toxicity. And then arbitrarily, we put patients in cohorts of 3. So it's similar to the 3+3 in that way. Oh, I didn't mention the 3+3 is the classic standard phase 1 design, where I'm not sure, you may not be familiar with this, so I should say it. So you put 3 people on at the first dose. If none has toxicity, you go to the second dose. If one of the 3 has toxicity, you enter another 3. And then if none of those 3 have toxicity, it's 1 out of 6, and you go to the next dose. And if 2 of those 6, if 2 of the first 3 or 2 of the first 6 have toxicity, that's too much. But of course, anybody could tell you that the statistical properties of this design are absurd because, is there really a difference between 1 of 3 and 2 of 3? No. Particularly because it pays absolutely no attention to who the patients are, but we'll get to that in a second. So, and then after each cohort, you compute the posterior probabilities of response and toxicity at each dose. And then you say, okay, are any doses acceptable for future patients? And basically, a dose might be unacceptable, in this example, if the probability of response, that's this R, probability of R, is less than 12%, because the historic rate is, say, 10%. And the probability of toxicity might become unacceptable at a dose if it's over 30%. And 30% is simply in between 1 out of 6, which is okay with the 3+3, and 2 out of 6, which is not. So 30% or 25% is in there. And basically what you're saying is, okay, these doses are unacceptable if the probability that the response rate is less than 12% is relatively high, in this case 90%, or if the probability of toxicity is over 30%, if that's relatively likely, say greater than 95%, then that's no good. And then basically you continue like this, and if more than one dose is acceptable, you pick the one with the highest response rate. And where do these, another thing that comes up is, well, where do these 0.90 and 0.95 come from? And I'll talk about that in a second. The 0.12 basically is based on historical data, and the 0.30 follows from the 1 out of 6 versus 2 out of 6 that I mentioned. So, and then the key to any kind of statistical design is you basically say, how does it operate? Here I set up my rules that I showed you, and in real life situations, in real life simulations, how does it operate? And so here what we have is we have 4 dose outcome scenarios. And so, for example, at the first dose, in the first scenario, which is reading left to right across that first row, at the first dose, the probability of response is 2%, the probability of toxicity is 10%. At the second dose, it's 5%, 15%, and so on. And in blue, you can see the doses that are acceptable. So remember, we said we'll accept it. We want to continue it if the probability of response is greater than 10% or 12%, and if the probability of toxicity is less than 30%. So in that first row, dose 3 and dose 4 are acceptable because they meet those criteria. And in the second row, the 0.20 and the 0.25, that's also okay. However, in the third row, no doses are okay because even though with each of them the toxicity is less than 30%, in none of them is there any response. So that's not acceptable. And this differs from the classic 3+3 rule, which pays absolutely no attention to response. So then the question is, what are the operating characteristics of the phase 1/2 versus the 3+3? And remember, we have 3 cases. And in the first case, doses 3 and 4 are acceptable, right, because they meet our criteria for efficacy and toxicity. In the second, only dose 4 is acceptable. And in the third case, none of them are acceptable. And so what you can do is you can calculate the probability of correctly selecting the dose. You want to pick one of those doses. And you're comparing the phase 1/2 with the 3+3. And you can see that, just about in all the cases, the phase 1/2 beats the 3+3. And, and it's intuitive because really what you're doing, the way the 3+3 works is it ignores data. So let's say you treat the first 3 people, and then you say, okay, we'll go to the next dose, we'll go to the next dose, and then eventually you come up with 2 out of 3 that have toxicity. That dose can never be revisited regardless of what happened before. It doesn't make any difference. So really what you're doing is you're wasting information. And of course in this, you're not. You're using the information from all the doses. So it's intuitive that the operating characteristics, the probability of finding the doses you're interested in is going to be higher with this kind of thing. So, so now here becomes interesting. So in the practical world, how would this actually operate? So let's say in the first thing, so I'm comparing the decisions for the second cohort based on what you see in the first cohort of 3 patients. Because in each, the 3+3 in this, the cohort sizes of 3 each. So in the first, 2 patients of the first 3 have toxicity. 1 is neither response nor toxicity. And what the 3+3 would say is, stop, decrease. It would either say stop the study or decrease the dose. And for mathematical reasons, the phase 1/2 would say stay. And let's say now you wind up with a situation where you've got 2 responses. That's the one in blue. No toxicity and 1 neither. The 3+3 would say increase, whereas the phase 1/2, such as the bendiitis study, would say stay because you're seeing responses and there's no toxicity. Now, you can get into arguments here because some people would say, gee, if there's no toxicity, why do you increase the dose? And so that's something where people can, talk about. But if you wanted to do that, you could set the design up so it would operate in this kind of way. To me, the key thing is that you're measuring response. And the fundamental assumption behind measuring response in phase 1 is this. If a drug is really good, efficacy is going to be seen at doses below the MTD. And it's amazing that nobody has actually ever written a paper about this because it's so fundamental. Because if you could actually show this, and I think you could, I mean with a drug like Gleevec or a drug like adhere or cladribine in hairy cell leukemia or adhere and APL, you would show that if you really have a good drug, you will see responses right away. Whereas if you really have a terrible drug, you probably never will see responses. And if it's really true that you can see, because the fundamental principle behind the 3+3 is why doesn't it, what you can do is you can go through 6 or 7 dose escalations, 21, 24 patients, not 1 response, and you're continuing with the drug. And people defend this by saying, oh, wait a second, you never see anything until you get to the MTD. Forget that none of these patients responded. Of course, that begs the question, well, if that's your principle, why did you treat these people at these doses to begin with? But more to the point is I dispute the idea, because I think if you have a good drug, you see it below the MTD. And if that's true, then it makes sense to monitor response in phase 1. But the basic point is you're looking at more than one thing. And as you know, medical practice is very, very complex. And the idea that the doctor is only concerned about one thing, and there's only one primary endpoint, and a lot of secondary endpoints that everybody ignores from a formal statistical point, is just not consonant with medical practice. And so, for example, let's say we're testing a lower intensity therapy. Well, you know, they might only measure survival. That's fine. But in addition to measuring survival, you might be interested in stopping if you decrease the CR rate by too much. Because, and this is another thing that is interesting to talk about, generally speaking, long-term remissions come from CRs. And, you know, so you may have somebody who's living 6 months rather than 3, but if the CR rate falls too much, then you're not going to have cures. And so you're really interested in monitoring both. You're interested in monitoring survival and CR. And that's the whole principle of these designs, is you want to monitor more than one. And then, for example, if you're doing a higher intensity therapy, you're interested in improving the CR rate. You don't want to decrease the early death rate. And you probably also want to measure that you're making sure that people go on the study. Because it's fine to have a study, but if the doctors say, gee, we don't want to put people on the study, then it's silly to continue the study. And you can monitor this kind of thing. So the whole idea is to, reflect medical practice is so complex that you want to take account for that by monitoring more than one outcome. So the next thing we can talk about is this heterogeneity, because all these designs have in common they ignore heterogeneity. And so even in phase 1, the patients are not the same, but yet the assumption is that, of course, they are. So about 8 years ago, this guy wrote this paper, and basically he said, okay, we're going to do a multivariate analysis, and we're going to figure out what are the covariates, what are the factors that determine toxicity in phase 1 studies. And the current assumption is it's only dose. 2 out of 3 had toxicity, that dose is screwed up, that's the end of it. But it's intuitive that if those 2 patients happen to be 80 and 76 years old, gee, that might have a role in it compared to if they were 62 and 54. But nobody pays any attention to that. It's really, it's almost embarrassing when you tell this to people, because they say, this is nuts, how can you do this? But this is what happens. So anyway, this guy Rogatko did this thing, and he said he looked at various drug combinations. And he said, what are the predictors of response? And so, for example, with this paclitaxel drug, the main predictor of response had nothing to do with dose. It did the patient have weight loss prior to going into it, you know? And okay, in the other one, dose in the whatever those 2 drugs were, I don't remember, but the alk-phos and the smoking were also independent factors. And in the tipifarnib one, the ones that determined toxicity were not the dose, it was the alk-phos and the albumin. So you can see the tremendous errors that you can get into by just saying the only thing that determined toxicity was the dose. So this is an example of the effect of heterogeneity in phase 1. And it becomes even more obvious in later situations. Because as you people know better than I do, it's through the work of immunopathologists that the heterogeneity, the tremendous heterogeneity of AML is recognized. And as that goes on, it's obviously going to be, you're obviously going to have more subgroups. And they're going to be treated differently. So, for example, people now say, gee, if somebody's NPM positive and FLT3 negative, they should get ATRA in addition to chemotherapy. And people say, if you have a DNMPT3A mutation, these are people that respond to decitabine and azacitidine, et cetera. So you have all these subgroups. But the common statistical design don't reflect this reality. So remember we talked about the 3+3 as a common statistical design for phase 1 studies. But the common statistical design for a phase 2 study is the Simon 2 stage, which is the S2S. And having spent my 1 year in the NCI when my wife refused to live in Houston, I worked with him. And even Dr. Simon, even in those days, we recognized that this design was had many, many problems. And we don't need to go into the technical problems with it. But one obvious problem is that it pretends that all the patients are exactly the same. But that's clearly not true. So if you have a drug for relapsed AML, or untreated AML, it certainly matters what the guy's cytogenetics were. But that's not accounted for. And of course the danger is, since you treat a relatively small number of patients, a good drug may be called bad, and a bad drug may be called good, depending on the entry by chance of particularly good or particularly bad patients. Because don't forget, you stop after 15 or 20 patients if nothing good happens. And we face this all the time. And so, for example, we're doing this thing, who knows if it's any good, where we give the cytidine, and then we give, on the day 6 of the cytidine, we give the 3+7. And it's supposed to have some epigenetic priming effect, but who knows if that's what happens, but it's certainly worth testing. And so we've done it, and so, there are like, 2 responses in 12 patients or something like that. And so most people would say, well, it's stupid, it's hopeless, stop it. But if you look at the likelihood that those 12 people would respond to, historical therapies, and this is relatively easy to figure out, you can't be totally sure because you're not randomizing, but the likelihood is that none of those 12 people would have responded. So instead of 2 out of 12 being bad and stop the study, well, 2 of 12 means, given that they're all 0, that the expectation is 0, that you should continue the study. So, but this Simon two-stage design makes absolutely no account of this. And sad to say, all these companies, all these CTEP studies, NCI studies, and drug company studies, this is what they do. This is the Simon two-stage design. And they make absolutely no accounting for prognosis. Now, so how do you deal with this problem, which, as I mentioned, is going to become more acute as people learn more about AML. So one extreme, which is the current, is to ignore heterogeneity. And the second extreme is to just say, okay, well, we'll just have separate trials for each subgroup. But here the problem is, you can't use the data from one trial to adaptively affect the conduct of the other. You can't use the data from one subgroup to affect, from one subgroup to adaptively affect the conduct of the trial in the other subgroup, because they're separate. You're not looking at them together. So then this third method is to consider the subgroup treatment interactions, STI, and adaptively use the data to see what extent subgroups can be combined. It's called borrowing strength. And I don't know if I should give this. It's a bit complex. Maybe we can go on. Well, I guess we will. All right, let's give an example. Okay, so basically the point is, if you do this, you have a better chance of uncovering effective therapies, for example, ATRA that I mentioned, than with the Simon two-stage design. And you're more likely than with the separate trials to assign treatment to patients likely to benefit. So let's look at an example of this. So I call this Fred after Dr. Applebaum, but Fred turns out that it's going to be an interesting drug, as you'll see. It's a hypothetical drug. So let's say we're doing people in first relapse of AML. It's their first salvage therapy. And the historical data, some MD Anderson database, showed that in 171 patients, the CR rate was 21%. And if your CR duration was less than a year, the CR rate was 11%. And if your CR rate, and if your CR duration was more than a year, the CR rate was 40%. So this is something that's well known, that generally these therapies, have some resemblance to each other. And, this is an aside, but, even though the drugs are nominally different, it's very striking that the thing that determines response to the new therapy is how well you responded to the old therapy. And it's interesting to me how people in transplant are very eager to regard transplant as a qualitatively different therapy. Yet it's easy to show that the same prognostic factors, length of first remission, cytogenetics, that affect the outcome of chemotherapy, all chemotherapy so far, affect the outcome of transplant. And in particular, people who go into transplant with minimal residual disease, that, this is work that Brent and Dan and people have shown, that if you start a transplant with minimal residual disease, you are much, much more likely to relapse than if you don't. And what does the MRD, the minimal residual disease, reflect pre-transplant? It reflects that the chemotherapy was not very good. So what it says is that bad chemotherapy means a bad result with a transplant. And so to me, it's really interesting that even though transplant and chemotherapy are supposed to be very different, and one there's a graft versus leukemia effect, and the other there's obviously not, that still, the same prognostic factors apply, and the differences are relatively, minor. Anytime you have to do a meta-analysis to show a difference, there can't be that big a difference. So there's something that's missing with both approaches, but let's get back to this. So now we have this new drug, and our goal with this new drug is to improve the CR rate to 31%, which is a 20% improvement in the worst group, and a 15% improvement to 58% in the better group. Thus, the overall targeted improvement is shown over there. 20% and 69% in the 69% of the patients, 15% in the other 31%. And so now let's say we're going to do a Simon two-stage design. And so the null, which is the rate that, the same old rate, you don't want that, is 21%. The desired improvement is 21 plus our 0.18 from the previous one is 39%. And as usual in the Simon two-stage design, we'll say we'll have a false negative rate and a false positive rate, each of 10%. And then you can just go to the table of the Simon two-stage design and plug these things in, and it says, okay, you enter 22 patients in the first stage, and you go to the second stage if you see a CR in 5 or more patients. And if you see a CR in less than 5 patients among those 22, that's the end of the design. And then, if you go to the second stage, you enter 21 patients in the second stage. So we're going to look at our little subgroup treatment interaction for this new drug. And just like the Simon two-stage, we're going to look after the first 22 patients. We'll have our false negative and false positive rates at 10%, but we'll consider subgroup treatment interactions. So I need to go through this. So here's how this would work. So let's say this should be this S2S that's on that separate line, that should be up over the 10. It didn't transfer that well, but okay. So let's say, and again, green. So let's say the true CR rate with this new drug, true meaning that if you had treated a gazillion patients, this is what you would see. In the better, it's 58%. So that's what you want because it met its goal. But in the worse, it's the same old 11%, so it's not very good. So here's the key, the probability that you would reject Fred. So with the Simon two-stage design, you don't look at anything that has to do with subgroups, so it's the same for both. So there's a 75% chance that you would reject Fred in both groups. But that would be the wrong decision because in the better group, it's a useful drug. It did what you wanted. And in contrast to the 75% probability of rejecting Fred, incorrectly rejecting Fred in the better group, with this method, there's only a 10% chance of doing it. And you can show the same thing is true for the worst group as well. And we don't really need to go through all this kind of stuff. But the point is that we ignore heterogeneity at our own peril. By actually thinking that all these patients are the same, this is just, not right. The next thing I think I'm going to try to talk about is this insufficiently adaptive thing. And I just made the slide yesterday. And basically, I called it protocol versus patients. And when you see patients every day, you really, really, really see how this is the case. And I'll just give one little anecdote. And I just saw a patient maybe 2 hours ago. And he's an 86-year-old physician, 82-year-old physician. And he's in really good health. And we've treated him, and he's relapsed. And he's got FLT3 ITD positive disease. It's a difficult disease to treat. And there's this new FLT3 inhibitor that's called PLX something. And it's a follow-up after AC220. But to be treated, it's a pill. But to be treated with this drug, the protocol actually demands that he has to come to the SCCA for 6 or 7 straight days for absolutely no conceivable reason. Well, he lives on Vashon Island. And, given the likelihood that this drug is going to work, which is very small because most drugs don't work, he said, gee, I realize that, if I don't be treated, I'm going to die. I've got a high white count. I'll be unhydrated and then I'll die. But to me, to come here for the 5 or 6 days is just not what he wants to do. And you say, what a stupid study this is, because all they're doing is losing a patient. It's not right from the patient standpoint. It's just not right. And so, that's an example of protocol versus patient in a very isolated case. But there's a fundamental problem, and it goes something like this. There's a huge constituency for success with new drugs. That's clear. Everybody wants it. The investigators are going to travel around the world if a drug is positive, not if it's negative. The pharmaceutical company, that's obvious. And the hospital wants it too, because a place like MD Anderson is predicated to some extent on the idea we have new drugs, patients come, the drugs are successful, more patients come, we have more new drugs, more patients come, and wow, we make a lot of money. And so one thing that happens, and I don't know how it happens, but it's certainly a very common observation, is you set the null rate, which is a rate of no interest, too low compared to the historical data. We actually wrote a paper about this. And so, for example, let's say the historical data says the historical rate, let's just say, is 40%. This is what you would expect with a historical treatment. So what the new design will say is they'll say the rate of no interest is 20% and the rate of interest is 40%. In other words, not any better than the historical. And thus the rate that's considered a success may not be higher if it can be obtained with the historical. And as you can probably intuitively see, is the consequence is that the trial continues. Patients continue to be accrued to the trial even when it's clear that it's not better than the historical. And I doubt many patients would want that. But this is something that really, honestly, happens all the time. And there are a lot of questions why that is. And I have some idea of the answer, but I'm not sure what anybody can do to change it. Another thing that comes up, and this is a trial that we did, this again is dealing with this protocol versus patient issue. And we did, in Houston, we did a study for untreated APL, and we said we're going to give people atrin arsenic, and that's going to be their sole therapy if they have a low white count. And of course, the standard therapy at the time was 3+7, or I guess it was just idarubicin and atra. And that therapy in these people with a low white count at the time was supposed to result in a cure rate of something like 90%. And of course, the obvious question is, well, how can you, this is really, you're talking about protocol versus patient. It's like whatever the expression is, the pot calling the kettle black. You're no one to talk because you did this study. In other words, you took patients with untreated APL with low white counts where the cure rate was 90%, and you proposed to put them on a treatment that was different than that standard treatment. And we just had this exchange in the JCO about this kind of stuff. And I guess our thinking was, of course you could say it's purely self-interested, there's no logic behind it, it was terrible. But I guess if I had to defend it, I would say, gee, if you don't do something new, it will never be 100%. It will always be 90%. And that is people feel different ways about it, but we said, well, let's at least quantify it when we do it. So we said if after entry of each cohort of 6 patients, the probability of CR or that you're PCR negative at 6 months was less than the historical, we would stop the study. The patients didn't come that quickly that we couldn't wait 6 months. So too low meant less than I guess it should have been 90% CR rate and less than a 75% PCR negativity rate at 6 months, which was our liposomal atra data. So then, as always, as I tried to show before, the way you evaluate the statistical design is how does it actually perform in various hypothetical situations. So if with our new therapy with atrin arsenic, if the true CR rate was 60%, okay, if that's what it really was, the trial would stop after a median of 12 patients. So those 12 patients would have a 60% CR rate, so there would be 7 CRs, right? Now, if they had gotten the standard therapy, which is ida and atra, the CR rate was 90%, so you would have 10 or 11 CRs. So really what you're saying, the potential cost of the trial is 3 patients. And this is a very, very, when people see this, they say, wow, this is really like, can you really do this kind of thing? But the question that really occurs to me is, what is the price of seeing a 90% improvement to 100% improvement? That's what you're trying to do. That's a worthy goal. But the question is it worth 3 patients that possibly could die? And obviously, so somebody might say, well, what happens if a CR is 40%? It would stop sooner, so it would come out the same way. And, it's a very difficult question because some people would say that's never justified. Dr. Esty, what you're saying is that the ends justify the means, and that is totally anathema to any principle of medicine. And other people would say, well, you're in a research institute, this is what you're supposed to do. You're supposed to improve things so that it's not always 90%. And this is, okay. And I think you could argue either way. And of course, we wanted to do the trial, and we took it to our IRB, and they said, okay, you can do it. But, it's another example of how you can get into this thing where you have got protocol versus patient. And this side, we probably were on the side of the protocol. And it turned out that the thing worked fine, but, we're lucky. So going back to the phase 2 trials, so they're not designed, another problem with them, so we talked about the fact that they don't account for heterogeneity. Another problem is that they're not designed to compare. That is, to begin with, they're single-arm studies. They take the drug where you found an MTD, and they say, now we're going to do a single-arm phase 2 study at that MTD. But patients, they're always asking, this is the question they always ask, well, you propose to treat me with this, but I can go to somewhere else and they'll give me this. And I looked at the website and here's this. And how does your drug compare? So obviously what they want to know is what's the best treatment. And so this is obviously comparison. But the Simon two-stage design basically just looks at historical data. There's no comparative data. And in addition, the way we do things is we waste data because the single-arm phase 2 is the most mature. It's been going on the longest. You've got a lot of survival data. But it can't be used in the phase 3, which is the randomized study. So it's just a waste. You're wasting data. You're wasting data that you accumulated in phase 2. So, and some people say, well, is there really a need for comparison at all? So this is a nice little example that we did in Houston. So we did trial 1 that was conducted a long time ago, and it involved treatment A. And then trial 2, conducted a little bit after that, involved treatment B. And they had, bad AML, and we did all this kind of thing. And what we tried to do is we tried to account for various things, their age, their cytogenetics, et cetera, to see if after accounting for these things, there was a difference between the treatments. This is something that we'd gotten very used to doing. And basically the way that it came out was, this is basically what it's showing, is that there was an 80% probability that the relative risk of death was greater with one trial than with the other. So that would say, gee, this is, as opposed to a p-value, here we're talking about probabilities. So, what's the probability that the risk of death was more with trial 2 than trial 1? Well, it was 80%, and 50% means you couldn't tell, 80%. But this is 80%. So most people would say, gee, I'd rather have the better drug. But in fact, both trials were the same. It's just that we did them in different periods. So what this seems to show is that you can really be, messed up if you don't randomize. And this is actually a little grant that I'm trying to write, and it's really going to, I think, be sort of fun. And basically, the question is, to what extent do you really need to randomize? And so, and of course, what's going on here is basically that there are a lot of unknown covariates that you don't know about. So if I were to ask the audience, let's say I account for age, cytogenetics, did they have an AHD, FLT3, NPM, CBPA, all these common things. And I'm trying to predict whether a given patient is going to be resistant. I have a lot of patients, and I want to predict how long their remissions are going to last. And we'll use this area of the receiver operating characteristic curve thing. And 1 means like you can predict everybody perfectly. 0.5 means you might as well flip a coin. You don't know. And so if I were to ask people, what is the AUC? Using all these factors, it's still only about 0.72. So despite all this knowledge that we have, about these things, still when it actually comes to individual patient prediction, there are a lot of things that are going on that we don't know about. And so obviously this is the case, we think, for randomizing. And now what we're trying to do is we're trying to get data from various places that give 3+7. We don't do that very much anymore. And from academic centers and from various HMOs in the US to see if after we account for these various factors that I mentioned, is there a difference in the outcome of 3+7? And if there was, that would certainly be convincing. That would say, gee, you just can't do this single-arm phase 2 thing, that you're going to be misled. There's no use doing it for comparison. So at any rate, I think there's this sort of paradox that the need to avoid treatment trial confounding is explicit in phase 3, because there are all these, the trial effects are all these unknown variables that you don't know about. But even though it's recognized in phase 3, that's why you randomize, it's ignored in the phase 2 study, which determines whether the phase 3 will be done in the first place. So at least to me, this seems very paradoxical. So based on that, we said, okay, we're going to come up with a selection design, and this is a very interesting story. So basically what we said, fundamentally what we're going to do is we're going to randomize patients among 3 to 4 new treatments, and we'd have a prior that was the same for each treatment, and we go through this whole thing. And the arm that did best would be selected for future study. And so this brings up a very interesting question, because what we were going to do is we were going to randomize patients among 4 drugs. And so people would say, oh, Dr. Este, what you're really talking about is an underpowered phase 3 study, because they're used to a power of 80%. So they said, well, obviously, if you have fewer patients, you've got much less power. It's an underpowered phase 3 study. It's not what you should do. So let's say, just as a typical thing, let's say that with 4 treatments, if you do this, and let's say you go through these operating characteristics, you've got 4 treatments, and let's say one is 20%, the 3 of them are the same as historical, and one is 20% better. Then the probability that you would correctly identify that 1 out of the 4 drugs is somewhere around 60%. And as I mentioned, people are used to typical power with 2 arms of 80%. So they say, oh, this phase 2 selection design is an underpowered phase 3. But the 80% power when you do a randomized study, for example, comparing a standard drug with a new drug, is purely nominal, and it ignores how the 2 arms are selected in the first place. And I think the next slide tries to go into that. Oh, so the next slide is sort of like my anti-intellectual slide and points out how much empiricism has been involved in coming up with successful drugs in leukemia in general. And each of these drugs has a story. But the one that I'm most familiar with is fludarabine and CLL. So we tried fludarabine in Houston in the late 1980s in AML. And at the doses that you needed to see some effect on the marrow, the people developed acute multiple sclerosis. It was the exact same pathology. And so obviously that seemed like that was the end of that drug. And then Michael Keating, who's really the father of CLL therapy with fludarabine and FCR and all that, basically said, well, CLL is a less proliferative disease than AML. AML is a more proliferative disease. Maybe we can use fludarabine at 25 milligrams rather than 150 milligrams per meter squared, and that's how it started. Now, it wasn't totally unscientific, but I doubt that anybody could get a grant on that kind of basis. But yet, that's where fludarabine came from. And each of these drugs has a very similar type story. And conversely, when I first started as a fellow, I was very impressionable, and I would read the rationales of these studies, and they all sounded so cool, as they sound so cool today. But in fact, obviously, many of them are routinely ineffective. So really what that says is that there's room for empiricism in leukemia research, and this is behind that observation is behind my view that this 80% power figure that you quoted is purely imaginary. So let's assume we have 4 new drugs, and assume that we want to pick 2. So assume the best 2, however, can't be selected without clinical data. That's that previous slide. You need the empirical observation. Then the probability that you select the best 2 is 50%. Or even simpler. Let's say you've got 4 new drugs, and I'm only going to pick 1 to compete with 3 plus 7. The probability that you're going to pick the best is only, that you're going to pick the best is only 25%. And that is what competes with the 80%. So really, it's 80% times 25%. And that, of course, is 20%. And so our 60% that I refer to over here really doesn't compete with 80%. It only competes with 80% in the world that you're sure that the drug you picked is the right one. You can pick the best of the 4 new drugs. But history suggests that that's not right. And so, in fact, you wind up with a true power of 20%, not 60%. And one way of just saying this is, given the empiricism that's involved, to me, for sure, the worst false negative is not investigating the new drug, is not investigating a drug at all, because somehow you conclude that it's not going to work, whereas another drug is going to work. But history suggests we're not that good at doing that. And, just as an aside, the thing that amazes me about AML is not that people are not cured, but that any people are cured. Because I think we know so little about the difference between the AML blast and, its normal counterpart, that it's actually amazing that, that these drugs cure people. I mean, ARC, it gave a 20% cure rate in 1969 or something like that. It's amazing how little we really know. And I think I don't think it's great that, that we pretend that we know more than we really do. And of course, the problem is going to become more acute or whatever in the future, because you're going to have many new drugs, and you're going to want to use them in very many different combinations. And the idea that you should just do this kind of thing, just one drug versus standard, is silly. But, so why isn't this done more often? So we proposed to do this in Houston, and we wrote a protocol. And what we're going to do is we're going to take untreated patients, we're going to randomize them between 4 different drugs. And it seemed to make sense, because that would answer what the patients are interested in. Of these 4 drugs, which one should I get? And if you don't randomize, as we mentioned, you'll have problems figuring that out. So we started, and then they came and they said, well, Dr. Esty, we don't think you should do this anymore, because the companies don't like this idea. And, so that was the end of that idea. And, it's really, I don't know, it's really ironic to me that you see these ads that the companies will have in the Blood or the New England Journal or the JCO, great drug, does this, hypomethylates, et cetera. But it really comes right down to it. Do you think your drug is better than another drug? That they're not willing to find out. That they want to delay finding that out as long as they can. It's a simple fact. And, I don't think that's really the way it should be, but it is. But in England, they're not probably as constrained. As a matter of fact, in England, because they have a national healthcare system, the drug companies have no choice. So in the United States, they could say, well, MD Anderson, you're doing this thing where you're randomizing people. That's fine. We'll just take our drugs to somewhere else. But in Britain, it's a little more difficult because all the patients with AML are treated under one aegis. And so they've done that. They sort of patted it a little bit after what we've done. They were very nice and thanked us in the paper. And I think this is going to be a great way to go, provided we can ever get it done in this country. It's being done more and more in Europe. And pick the winner is exactly what we're talking about. You randomize among a few arms, a relatively small number of patients, you pick the best one, and then you investigate it further. But their thinking is that the worst false negative is not doing it at all. So we don't need to go into this. But I guess the thing that I really want to talk about here is the phase 3 study. And so the typical phase 3 study in AML goes like this, because we talked a little about phase 1, how we think we should monitor response and toxicity both, because we think we're going to see response even at doses below the MTD. We talked about the huge problem with heterogeneity. The dose is not the most important factor in determining toxicity. We talked about how the problem with all these different molecular variants of AML, if you just lump them together, you can be very misled. We talked about how you need to compare as soon as you can by randomizing and what happens if you don't. And we talked about how you can randomize with small trials and then proceed to a larger trial later on. But this takes us to the last thing, which is the typical phase 3 trial in AML. And so if you read these references, and I doubt very much has changed, they typically enroll around 400 patients so as to detect very small gains. For example, in these papers, 10 to 20% in 2-year event-free survival, 6 to 12 months in median event-free survival, 50 to 65% CR. They always want a false positive rate of 5%, that's p less than 0.05. They always want a false negative rate of 20%, that's power of 80%. And so the critique, I'll start and I'll say, to me, the targeted gains are medically insignificant. And this is a nice little example that I show patients. So azacitidine is the only drug that's been shown to improve survival in a randomized trial in high-risk MDS. The median survival in IPS poor cytogenetic patients was 17 months with azacitidine versus 6 months with conventional care regimens, and it was statistically significant. And so now the authors of the paper said that this should now be considered the first-line therapy for high-risk MDS. And the implication, the term they use is standard of care. And of course, that implies that if you don't do that, you're like not following the standard of care and you should be shot. But if you actually look at what this is actually translate to, and this is something I show patients. So if you look at the Social Security table, you can see that if you're healthy and 68, you would expect to live another 15 years, 180 months. Now, contrasted with conventional care regimens, azacitidine increases life expectancy by 11 months. That was the previous slide, 17.2 versus 6. Thus, and now if you do the arithmetic, thus the patient still loses 94%, which is that figure, 168.8, that's over 180. 180 is what they normally would do. And now you save them 11 months, right, with the azacitidine. But they still lose 94% of their anticipated life expectancy. So when you go and you show this to patients, okay, we can give you the standard therapy, and it's statistically significantly better, but people often confuse statistical and medical significance. This is a huge problem as far as I can see. And you can see that, when you see these ads in these medical journals, p equals 0.043678, like, there's something magic about 0.05, but the absolute difference is somewhere on this order of magnitude. Now, so if you present this information to some people might say, well, Dr. Esty, you're going to do a clinical trial, and for all I know, it's going to be worse than azacitidine. You know, instead of 11 months, I'm going to lose 11 months. I'll do the azacitidine. But many other people would not say that. They would say, 11 months, this is all you have to offer me. I'm willing to take a chance on something new. I realize it might be worse, but it can't be much worse than only living another 11 months on average. Now, of course, if we were smart, we'd be able to say, because that 11 months is an average, you'd be able to say, oh, given X, Y, and Z, or your response to azacitidine, you're going to live 31 months, not 11, and that would change the argument. But right now, we're really not very good at doing that. So when people speak of the standard of care as azacitidine, I think it ignores this process, this complexity, and I think it's fine to call it the standard of care if you're saying that's what things should be compared to. But to imply that if you don't do that, that you're somehow doing something that's really wrong, I just don't think that's right. So that's one problem, is they aim for too small an improvement. Remember, we're saying that they're very, very large. One problem is they're very, very large. And because they're so large, they're only investigating 2 therapies, they go on for years, and you don't get a chance to investigate other therapies. And one of the reasons they're so large is because they're interested in detecting small gains. Obviously, if you want to find a big difference, you don't need as many patients. And then they want this false positive rate of 5% and a false negative rate of 20%. And as I think I mentioned earlier, this 5% and 20% formulation is true for every study. You can look in the New England Journal of Medicine, and it's true for studies of hypertension, it's true for studies of whatever disease. And you think about it, and then you realize that what I think happens, and I know that happens, physicians are very afraid of statisticians. They are afraid of appearing dumb. You know, they don't know, you know, they're stupid. Somehow they have this idea that math is some kind of magical thing. Well, I majored in it, so I don't think it's that magical. If you think about it for a second, what it's saying is we're more willing to accept a false positive than a false negative, right? No, I'm sorry, we're more willing to accept a false negative than a false positive. A false positive is complete anathema. And then you say, well, can that be true in all diseases? Yes, if you have hypertension and you've got all these very good treatments, and you do a trial and you falsely declare a new drug falsely positive, then the old drug is replaced by the new drug, and the old drug was pretty good to begin with. That's a very, very bad medical consequence. But in AML, if you replace, you know, a terrible treatment with a treatment that's not much better, that's not so bad. So the consequences of a false positive totally depend on how good the standard therapy is. And how good the standard therapy is not the same in all diseases. So this formulation, this thing where we want to avoid a false positive, doesn't really make medical sense to me. But I think what happens is the doctors are afraid of actually saying anything about it. We used to call it the tyranny of the statisticians. And consequently, you could also say, gee, you know, if anything, why can't we make both these rates 10% or 15% or whatever, and you would require fewer numbers of patients. But again, I think there needs to be some kind of flexibility. And we were always taught in Houston, they said, well, the false negative is much worse than the false positive. And they said, because if it's a false negative, you never investigate it again, where if it's a false positive, you eventually find it out. But of course, the problem with that is that, you know, you're wasting time following up this misleading thing. So finally, my suggestions, if I were going to do this, would be something like this. I would say, gee, why don't we aim for larger improvements? Why don't we get away from this magic p equals 0.05 and, you know, focus on, and that, because then you'd need fewer patients per study and you could study more therapies. So I could go on, but why don't I stop and allow time for questions probably? So, you know, I think the designs are problematic. They're insufficiently adaptive. In other words, there was this protocol versus patient thing. They oversimplify medical practice. They're focused on one outcome when the doctor who's seeing the patient is focused on many. They're looking at many things. They ignore the issue of how are we going to deal with all these new treatments. They artificially separate phase 2 and phase 3. There's a blind reliance on the p-value. And the statistical literature is just, there are loads of these new things in the statistical literature. But as I said at the beginning, the trial designs haven't changed in at least 30 years. And I think a very good question is, you know, why is that? So that's it.